I am truly privileged at this opportunity that EMAS has provided to talk to you about low bone mass in the perimenopause. I'm a gynecologist and a reproductive endocrinologist, and I'm hoping to share my perspective of approaching skeletal health in an aging female. These are my disclosures. They have no relevance to the talk that I'm giving, but I just wanted you to be aware of this. So over the that we can collectively appreciate the relationship between ovarian physiology and bone mass, understand the determinants of bone mass. So I sort of approach bone mass or bone density as a retirement account. Just like the workforce, when we are working, we have a job, we are earning, we are putting money in our cash retirement account so that when we retire, we can then draw on that money and survive and have a good quality life. Our bone mass has to be approached in a similar concept. When we are young, we are through the effects of hormones, primarily in a female biology particularly. Estrogen is a big player, but also dietary factors, general health factors contribute to us gaining bone when we are young. And menopause should be considered around about the retirement age. And beyond that, we are losing. We are sort of drawing on our bone mass for the rest of our remaining years. So determinants of bone mass in younger age need to really be valued and prioritized. We'll talk about the definition of what is low bone mass, appreciate the relationship between the low bone mass and fracture risk. That really is what we are talking about. Low bone mass translates to fracture risk. And then tailor management strategies for low bone mass based on an individual patient profile. And again, I'm approaching this question from the perspective of a reproductively aging woman. So how do we prioritize which drug to use, when to treat in a perimenopausal woman who still has a few decades ahead of her, hopefully. So we want to choose the right tool for the right patient. So why focus on bone mass? Why are we even talking about bone mass? So really putting in perspective that over the course of a population's life, the health burden related, and this is a bar graph. I hope you'd be able to see the cursor that I'm moving. Osteoporotic fractures, the incidence of osteoporotic fractures and the health burden on the system from osteoporotic or fragility fractures far outweighs the burden from other common chronic conditions that lead to health incidences such as heart attacks, stroke, and breast cancer. So from a public health perspective, from a personal perspective, from a family's perspective, skeletal health-related harm over the course of a person's life can really dominate the health concerns. And that's why we want to talk about bone mass. So this is a pictorial assessment. To your left is a panel that identifies what a normal bone looks like. And these are thick trabeculae with bone marrow spaces in them. And this is really a bone which it's almost like the springs in our car that allow us to go over bumps without really our chassis hitting the ground. So it's a very robust skeleton, which allows for bending, which allows for stresses without breaking. And the panel on the right, you can see these are brittle, thinned out trabeculae, widening of bone marrow spaces. So this is like a dried up stick or a twig, if you will, that when a stress happens, this fractures, this snaps. So the whole idea of understanding bone is to appreciate two concepts. One is bone quantity and one is bone quality. And osteoporosis, by definition, is deterioration in bone quantity as well as alteration and deterioration in bone quality. And as the population ages and as an individual ages, our bone quantity starts to go down and our bone quality starts to deteriorate. So this is a concept it's important for us to keep in the back of our mind. Now, bone is a dynamic organ, and the bone is a dynamic organ that is continuously being formed, and old bone is continuously being removed to allow new bone to be laid down. Number of hormones, number of metabolic signals, and number of electrolytes players are in this game. And this is a schema which identifies two major players. this on the left, the large cell is the bone reabsorbing cell, or the osteoclast, and the smaller cell is the bone forming cell, or the osteoblast. And the blast and the clast are continuously having a dialogue with each other through various molecular mechanism, with the osteoclast getting rid of old bone and the osteoblast making new bone. When we are young, particularly around puberty, the osteoblastic signals dominate and we land up getting more new bone laid. As we start to age, and particularly with late perimenopause and menopause, this signal from the osteoclast dominates, and bone loss exceeds bone formation, so that there is a net bone loss. And a postmenopausal woman within the first 5 years of menopause can lose up to 5 to 10 to even 20% of her total bone mass due to overactivity of the osteoclast. So again, going back to the concept of retirement account, if I have a small retirement account, small cash reserve, I'm going to lose bone mass in perimenopause and minimizing bone loss as we enter into menopause, so that we continue to have a large retirement account that will stay with us for a long time. And the goal is to prevent fragility fractures as we age. So this is the schema, really simplistic, that what happens when, what I've already mentioned to you. So this is an activated osteoclast. The red signals really direct you to what happens in the absence of estrogen. The activated osteoclast, normally in the presence of estrogen, should be directed towards appropriate removal of dead bone, and then committed to apoptotic death, so it doesn't hang around for too long. But in the absence of estrogen, the activated osteoclast's longevity increases. So it lands up staying for a longer time, doing its action for a longer time, and resulting in net bone loss. So just to familiarize, just digressing from bone to reproductive physiology, this really is to bring everybody to focus that what is the spectrum of reproductive aging in a female. So this is a schema. It's a modified figure that reflect from the STRAW 10 conference that talks, so Stages of Reproductive Aging Workshop 10, that outlines the stages of reproductive aging in this upper blue bar. The green triangle identifies onset of puberty, menarche, which really is a hallmark of pubertal peak, if you will. And then menopause, which is the hallmark, which these are two bookends. So menopause is the end of that reproductive hiatus. The pink horizontal line identifies the phases of reproductive stages of life. So a child goes through menarche and enters the reproductive phase of life. And that reproductive phase of life itself has many stages. So early stage, mid stage, and then late stage. Menopause transition is what today's talk is all about. And menopause transition itself is a span. It can span 2 to 4 years of timeline. And then the final menstrual period really identifies the beginning of menopause. And menopause itself is a spectrum. So there are stages of early menopause and then late menopause. And why are these concepts important? Because a lot of clinical scenarios are changing across this continuum. So I'm just going to focus on menopause transition. What happens with menopause transition? In early stages of menopause transition, women may start feeling some hot flushes and night sweats. Menses may become irregular slightly, so they may start having either shortening of menstrual cycles or maybe skipping some menstrual cycles, and fertility is declining. Now, this is also the time where bone mass starts to decline, particularly in -1 stage, which is late perimenopause. And when you look at the hormonal population, you start seeing that early follicular phase FSH levels start to rise, anti-Mullerian hormone levels start to decline and may even go undetectable, and inhibin B levels start to decline. And if you do an ultrasound scan to look at the ovaries of these women, you see very few antral follicles, which are ovarian follicles less than between 2 to 10 millimeters in size. So this is where what we are focusing on, and our interest is really to try and understand the relationship between the endocrinology and what's happened at the level of the bone mass. So this is a cartoon schema which really puts the bone in perspective. So bone mass across the lifespan. Again, the pink bar is sort of identifying the phases of life. The green is a simplistic representation of what happens to our bone mass. So premenarchal, young childhood, bone osteoblasts are functioning, osteoclasts are functioning, but at low level state. As the puberty starts to happen, endocrinology, reproductive endocrinology is kicking in, you can see an upstroke into the bone mass. So bone accrual starts to happen as a child goes through pubertal changes, estrogen comes into play, and the pink and the yellow lines are reflecting markers of bone metabolism. The pink reflects the marker of bone formation, which is osteoblastic function, and the yellow reflects osteoclastic function. Recognizing that as bone is forming, bone reabsorption gets up too because it wants to get rid of the old bone. So when we are young, the net metabolism is favoring bone formation. When we get old, the net metabolism is favoring bone resorption. Bone mineral density starts to decline in late perimenopause, early postmenopause, and then eventually starts to plateau as into late menopause. So this really are the concepts that we all need to be familiar with. This is a slide from a study from a SWAN study of women across nations. It's a long term follow-up of women as they go from premenopause into early perimenopause, into late perimenopause, into postmenopause. And the longitudinal study is looking at bone mineral density changes. So bone mineral density in grams per meter square per year. And I just want to bring your attention to these bars. Downward decline is loss, upward upstrokes are gain. So compared to premenopausal women, early perimenopausal women, nothing much is happening. But it's the late perimenopause that the bone loss starts to happen, and then it peaks into as a woman goes into the early postmenopausal phase. So again, underscoring the concept that perimenopause is a state of a bone decline. So if you're dealing with a woman who is at risk for fracture already, she's going to get worse as she ages. So let's bring our attention to a case which I'm hoping will bring us all together on this concept. So this is a 46-year-old Caucasian female with a 6-month history of irregular periods, bothersome vasomotor symptoms that are really affecting her quality of life and her sleep. Her personal history is significant for having sustained a fracture last year at age 45. She is hypothyroid on supplementation. She also has some gastroesophageal reflux and is using proton inhibitors. So this is a bread and butter patient from my clinical practice. She does have a family history of osteoporosis in her mom and her maternal aunt. Her sister at age 58, who was menopausal, developed breast cancer, and the patient really, in this whole scheme of things, is worried about her personal risk for breast cancer and comes to you with this profile. She has fractured before, she has got a few medical conditions, and her psychological stress is about, I really don't want to take anything that will affect my fracture risk, my breast cancer risk. So the questions dealing with this patient, number one, is she at fracture risk? She's young, she's only 46. Should she initiate any anti-fracture treatment? Which of the following treatment options should be preferred as a first-line approach to manage her fracture risk if we believe she has a fracture risk? So we have a whole slew of possibilities: bisphosphonates, parathyroid hormone, denosumab, and I'll touch upon each of these strategies. Menopausal hormonal therapy, a selective estrogen receptor blockers such as raloxifene. In United States, we are increasingly seeing the use of TSAC, tissue selective estrogen complex, which is a combination of conjugated equine estrogen, and bezodoxifene, which is a SERM. It's available as Duavi. And calcitonin, which really is more of from a historical perspective, not really in use anymore. So these are the questions that come to mind from the bone angle when dealing with this young woman. So let's just then focus on how do I assess her fracture risk, this patient's fracture risk, who is 46, who is not menopausal yet. She has irregular periods, so I do believe she's gone into perimenopause with hot flushes. So she is destined to lose some bone, and she has lost her bone. She has had a personal fracture already and has a family history of fracture. So we have a few things available to us to quantify fragility fracture risk in a patient. And one of those commonly used scenarios is assessing bone mass, bone mineral density, doing something called dual X-ray absorptiometry or DEXA, which is the clinical standard for measuring bone mass. We can also look at bone metabolism, so markers of bone formation and or bone resorption, to give us a snapshot of what is happening to her skeleton now. And then we can focus on clinical risk profile without doing any other thing. And FRAX is fragility risk assessment is one of the tools that is really available to us, but there are many other tools that quantify a patient's risk without even needing DEXA, to give us a sense of this individual at risk, and therefore should I be doing something about her now? So just a quick review of interpreting bone mineral density when doing DEXA. So dual X-ray absorptiometry or DEXA gives us information about bone mass in the form of bone mineral density in grams per centimeter square. That bone mineral density in grams per centimeter square is interpreted in the context of bone mass for a young, healthy population. And so the mean bone mass for a young, healthy population is demonstrated on this slide by this hashed yellow or orange line. And then this gray zone identifies the standard deviation across that bone mass for the population. So just to go over this particular graph, the horizontal axis here identifies the age of the population. The vertical axis towards the left identifies the bone mass in grams per centimeter square, and the vertical axis on the right translates that bone mass into standard deviations. And this horizontal line I have said to you is the mean for bone mass for the young, healthy population. White line identifies the mean bone mass for the population as they age. And what you can see is that as the population is aging, the mean bone mass starts to go down as we age. And there is a standard deviation variability around that mean. So this 59-year-old patient that is presented on this slide has a bone mass of nearing 0.960 grams per centimeter squared. This is where this person lies. So her bone mass compared to the bone mass of a young average population, this distance is what is the T-score. And where her bone mass differentiates from the mean for somebody her own age, is the comparison is the Z-score. So we are comparing a patient's bone mass compared to the average bone mass for the young, healthy population as T-scores. And then we're also looking at her bone mass compared to somebody else, her own age and her race, so the Z-score. So these are the two concepts that these are important to be aware of. When we identify somebody as having osteoporosis or osteopenia or low bone mass in a postmenopausal population, we are comparing our patient's bone mass to the mean average for the population and talking in terms of T-scores. When we are dealing with a premenopausal woman, we are comparing the bone mass compared to somebody else, her bone age, and we are talking about Z-scores. So I hope this is clear. And so diagnostic criteria, the categories that the World Health Organization has identified that we all follow, really relate to what is a normal bone mass for a person. And a normal bone mass is a T-score that is better than or equal to -1 standard deviation. So I'm again going to go back to the previous slide, and I'm talking about this difference to this difference. So I'm talking about a bone mass that is better than -0. So it's on the higher side. That's normal. Low bone mass, previously we used to use the term osteopenia, but we don't really now. Talking about low bone mass is a T-score between -1 and -2.5, and osteoporosis is a T-score of worse than -2.5. So osteoporosis is anything worse than here for this person. And when we are talking about premenopausal women, low bone mass is anything worse than -2 standard deviations, so less than 2 standard deviations compared to somebody your own age. These concepts are again important, and depending on which facility and which device you're using, you get the results for your OAP spine as well as the hip, including the femoral neck and the total, and then the results are plugged in for the patient, and then as the patient ages and undergoes repeat assessments, you, the clinician, can follow the changes in her bone mass as she is aging. So back to our patient, she undergoes, I'm worried about her, I got a bone density on her, and her mean femoral neck T-score is -2.6. So because she's a bit older, because she has stepped into perimenopause in my clinical assessment, I can use a T-score for her rather than focus on the Z-score. And based on the T-score, she's meeting criteria for osteoporosis. And now remember, she has fractured before, she's hypothyroid, she's using certain medicines, which may also have for bone health. She comes from a family where osteoporosis was also there, so I do believe she is at risk for bone fracture. So that brings us just to the concept, what are the risks to a premenopausal skeleton? I've already touched upon this. Family history is important, race is important. So Caucasian race, comparing the races, Caucasian race, as a race, Caucasian skeleton has less bone mass than a skeleton of African ancestry. Late menarche, early menopause, all risk factors for low bone mass. Infrequent menses, which relate to inadequate estrogen production during reproductive life, has also been linked with low bone mass. Eating disorders, excessive exercise, chronic stress, depression, low body weight in of itself, smoking, malabsorption such as disease, vitamin D deficiency, all are risks to the skeleton. Medication, so excessive use of thyroxine, an iatrogenic contributor. So when you place somebody on thyroid supplements, it behooves us to monitor and make sure we're not over-treating them. Anticonvulsants, glucocorticoids, direct damage at the level of the skeleton, Depo-Provera as a contraceptive agent or when used for managing, say, endometriosis, brings about hypoestrogenemia as a mechanism for bone loss. GnRH agonists, antagonists bring about medical menopause and therefore take away the estrogen. Aromatase inhibitors, again, lack of estrogen, inhibition, conversion of androgens to estrogens bring about excess osteoclastic dominance. Antidepressant, so depression in of itself has been linked to bone issues, and then use of antidepressants, depressants such as SSRIs. And then proton pump inhibitors themselves have been tied into low bone density as well as fragility fracture risk. Pregnancy and lactation are transient states of bone loss. So when dealing with a young person, you really also need to keep that in perspective. Some studies that explain infertility has been linked with low bone mass and exaggerated bone loss. Hot flushes and night sweats in premenopausal women, in perimenopausal women have been tied in with excessive bone loss and bone mass. So all these are risk factors. So back to our case then. So I've already talked about she's Caucasian, she's having hot flushes, she has irregular periods, she broke her wrist, she is osteoporotic by BND, she is on a thyroid supplement, she's using PPIs, and she has family history. All these are her risks for fragility fractures. So now that I have really identified her as being at risk, should I be doing something else? So bare minimum workup to evaluate that you're not missing any secondary causes of bone loss. So serum chemistry with particular focus on kidney function, liver function, calcium and phosphate. CBC, so hematological conditions such as sickle cell, thalassemias, they have been linked with osteoporosis, bone loss. Hypothyroidism, extremes of hypothyroidism and hyperthyroidism have been linked to poor bone quality, bone loss. Hyperparathyroidism, whether primary or secondary, so vitamin D should be looked at. Bone turnover markers can give us a snapshot sense, don't have to be done, but in some situations they may be of help. Understanding her reproductive status, where is she? So if she has evidence of elevated age, low estradiol, you're identifying these go hand in hand as identifying her as perimenopausal. 24-hour urine for calcium creatinine. If you are suspecting hypercalciuria as a mechanism for her loss, or if you're suspecting her calcium intake is not adequate, you could do that. If a patient you're suspecting Cushing syndrome as a mechanism, check a urinary free cortisol, particularly in older people. Multiple myeloma, so check a total serum protein. Hemoglobin electrophoresis, if RB, red blood cell indices are abnormal, and you're suspecting hematological mechanism for bone loss. So this is a bare minimum workup. Bone markers, again, I'm not going to belabor this. There are urinary markers, there are serum markers. So bone reabsorption markers really tell us more of osteoclastic dominance. Bone formation markers tell us about bone osteoblastic dominance. And a combination of the two is really identifying the walls between the former and the reabsorber. So in my clinical practice, I do check serum C-telopeptide and bone-specific alkaline phosphatase if I'm trying to understand if treatment is working for a patient, or if I'm trying to understand low bone mass in the setting of a stable skeleton. Is she, a low bone mass in a young person, is she losing bone, or is this what her inherited peak bone gain was? So I'm now going to switch gears, and I've already hopefully conveyed that our 46-year-old has a lifetime increased fracture risk. How should we be approaching a person to reduce fracture risk? And we really are doing a multi-pronged approach. So yes, low bone mass should be addressed, but fall risks should also be reduced. Muscle strength should be improved. We need to pay attention, particularly in the aging population, that, patient is not falling because she has musculoskeletal coordination issues, but she could just not be seeing things right. Maybe it's a cognitive contribution to imbalance. So many things need to be looked at. Optimize calcium, vitamin D, as you think about what pharmacotherapy should we be focusing on. So the questions for the clinician are who to treat. What am I treating? Am I trying to prevent something? Versus I need to intervene and treat something such as established osteoporosis. So do I prevent progression towards osteoporosis, or do I treat osteoporosis? When to treat? So do I wait till she becomes osteoporotic before I treat? Or do I treat like our patient till she becomes menopausal? Or do I has low cash reserve in her retirement account? She has not quite retired yet. And therefore, maybe I should intervene now to prevent progression. And then what agent should I use to treat this perimenopausal woman? So again, I've touched upon the agents available before: anti-resorptive class, estrogens, bisphosphonates such as alendronate, rosindronate, SERM, selective estrogen receptor modulators. The commonest is raloxifene. The TSAC, which is the combination of an estrogen and a SERM, is available, at least in the United States. That is now increasingly being used. Calcitonin is an sort of retired agent now. Denosumab is a new kid on the block with excellent efficacy for fracture risk reduction. Its use in perimenopausal populations is really, data are sparse. And then we have the primary anabolic agent available to us still is the parathyroid hormone analogs. And then we really can't dismiss the importance of vitamin D, calcium, even vitamin K. Strontium is available in certain countries, not in the United States. And the data about safety of strontium use has come under question. So we in US are really not using it. I'm a big proponent of using lifestyle modifications and physical exercise, weight-bearing exercise, and therapy to optimize the skeleton. So when I'm trying to choose a treatment agent, really the things to focus on: what is the age of the person I'm working with? What is the expected longevity of the agent? So I want to make sure I choose an agent that prevents harm and does not add to aging-related risk. For example, bisphosphonates, when used, stay in the skeleton for decades. So if a woman has 30 years life prognosis ahead of her and I start her on a bisphosphonate early in life, I should be looking at thinking about this skeleton should need drug holidays going forwards, because otherwise I may contribute to her lifetime risk of really uncommon scenarios, but they become common as you extend the duration of treatment into decades, such as atypical fractures of femur and osteonecrosis of the jaw, which have been described with long-term use of bisphosphonates. So site-specific fracture risk. I want to know what is the lowest point of bone mass in her skeleton that she is at risk for. Because if her spine is at risk, I'm okay. But if her hip is at risk, there are certain agents that really have not shown efficacy in fracture risk reduction at the level of femoral neck, such as raloxifene. Raloxifene is excellent for the vertebrae, but has not shown risk reduction for the hip. So I want to know what to quantify and individualize the person's risk. Menopausal symptoms, is this a symptomatic woman? Because if this is a symptomatic woman, I really need to be choosing a treatment, if possible, that addresses her quality of life as well as offers her risk reduction. And then what are her comorbidities that I need to address? So if she has a personal history of stroke, thromboembolism, menopausal hormonal therapy should not be my first line agent coming up. If she has a personal risk of breast cancer, maybe I need to be considering a risk reduction strategy such as raloxifene or a SERM, which not only offers skeletal protection at the level of the vertebra, but also gives you breast cancer risk reduction. Or maybe I should consider a TSEC, which gives me a combination that skeleton is benefited and there's no direct harm to the breast. So these are the things that I should be thinking about. So identifying the best option, again, I've talked about, and I'm just revisiting, which drugs should I use? What are the pros and what are the considerations? So if I'm choosing bisphosphonates, the pros are it's most effective against vertebral and non-vertebral fractures. And there is such a variety of bisphosphonates that are available daily by mouth, weekly by mouth, every 3 months by mouth, intravenous, once a year, IVs, many options available. It has considerations are prolonged half-life is a concern in young women, particularly if there is a probability of future fertility, because this agent can be chelated out of the bone, does cross the placenta and go to the fetal bones, and long-term effects of that exposure are completely unclear. And I already talked about concerns about atypical fractures and osteonecrosis of the jaw with long-term use if I'm looking at decades of use ahead. Parathyroid hormone, excellent vertebral and non-vertebral benefits. We can only use it for up to 2 years. That's where the safety data are. Beyond that, we need to go somewhere else. And if we don't use that second agent, all the benefit of PTH is lost. So PTH is really used for high fracture risk populations to stabilize them and then switch them to an alternative strategy. Raloxifene or a SERM is an excellent agent against vertebral risk reduction. It does not help with hot flushes. If anything, it can make things worse. It has not been shown to have risk reduction against hip fractures. So if you are worried about hip fracture risk, this is not the agent you would choose. Denosumab, again, an excellent agent, but I already mentioned to you, is it not approved for use in perimenopausal women, long-term data in this population are not available. Menopausal hormonal therapy is an excellent strategy for skeletal benefit, addresses hot flushes and night sweats. Risk reduction can be achieved. So menopausal hormonal therapy has its own risks, which are if there are risks related to what dose are you using, what route are you using, what combination are you using, risk of stroke, risk of thromboembolic phenomena, risk for breast cancer with combination estrogen progesterone therapy. So vascular risks can be reduced with transdermal route and lower dose regimen. So really, this is a very powerful tool in the hands of gynecologists, particularly for managing skeletal issues in young perimenopausal, early menopausal women. And I do believe the TSEC, which is the combination of conjugated equine estrogen and BZA, is an excellent alternative, particularly for patients who are psychologically worried about breast cancer risk, such as our patient, but whose absolute breast cancer risk may not be high. Remember, our patient's sister had breast cancer at age 58, postmenopausal breast cancer, and she is not carrying any of the risk factors, genetic risk factors. Calcitonin, like I said, is really more of a tired agent. Some benefit if you're dealing with back pain associated with low bone mass and metastatic lesions in the spine, in the skeleton. It does have some analgesic effects. So that really is a very subset that this may offer some benefit. So choosing the right agent from my perspective, I would say quantify the age of the individual, quantify that person's risk, recognize that as we age, our risk goes up because we're losing bone and the bone quality is changing as well, and put into perspective how bad is this person's risk. So for younger population, menopausal hormonal therapy is a great option for symptomatic women, gives them symptom relief, and mitigates bone loss, adds to bone gain, but importantly reduces fracture risk. SERM, selective estrogen receptor modulator, excellent strategy for asymptomatic women whose risk bone loss, low bone mass is lowest at the spine, and the personal risk for breast cancer is high. That's a good strategy. Bisphosphonates can be used for anybody as long as you have a rationale for why am I choosing this for fracture risk reduction, because it really is an efficacious class of agents. Denosumab, excellent strategy for an aging population. And then parathyroid hormone, which is short 2 years use to maximize bone gain in people who high fracture risk. So that's the schema that I work with in my clinical population. So back again, I'm underscoring, look at the patient profile, and then that'll guide you towards the first line of treatment. A compliant older patient who does not have GI issues. Remember, bisphosphonates by mouth can worsen gastrointestinal abnormality issues, gastroesophageal reflux, poor tolerance. So if somebody is without GI issues, and remember our patient that we have discussed has gastroesophageal reflux and is on a PPI. So PO of bisphosphonates, great strategy, low bone mass, reduced fracture risk, and an older person with no GI problems. Older person with gastroesophageal reflux, non-oral bisphosphonate or denosumab, great strategy. Symptomatic early menopausal woman, when she does have a uterus that is present and is personally at a low risk for breast cancer, transdermal estrogen with a natural progesterone, great strategy. If she has no uterus and is symptomatic and alone, again, transdermal to reduce her risk for vascular phenomena. If she does have a uterus and there are concerns regarding breast cancer risk, you may choose to give a TSAX, estrogen plus BCA. Who has a family history of breast cancer or a personal risk for breast cancer, you want to use a SERM such as raloxifene. Older patient, poor dentation, high fracture, that's a marker for fracture risk. Parathyroid hormone is a good strategy. Older patient who can't remember to take things, maybe an IV bisphosphonate or every 6 months denosumab. Kidney renal insufficiency, denosumab may be the first line strategy. Patient in a nursing home, now we're talking elderly people, IV bisphosphonate or denosumab, somebody else can police and administer the agent. High risk for fracture, PTH, back pain with metastatic disease, calcitonin. Again, I'm underscoring what I've already talked to you about. And again, underscoring that for our patient, again, perimenopausal patient who does have a uterus, she has a personal low risk. She doesn't have a high risk, even though her sister developed postmenopausal breast cancer. Estrogen plus progesterone. So transdermal estrogen plus P is an okay strategy for her, or you may choose to give her a TSAC for her psychological wellness. Now, recognize that no matter what we are doing, we cannot ignore the importance of vitamin D supplementation and calcium daily supplementation. Our patient falls into this age category of 19 to 50, and the recommended daily allowance for calcium, pay attention to that. Upper limit for calcium intake, recognize too much of good thing may not be good. High calcium intake has been linked with some surrogate markers for cardiovascular disease, including coronary calcification. So optimize dietary intake of calcium, add supplements as and when needed, maximize vitamin D intake, recognize that recommended daily have normal circulating D levels. If you're dealing with D deficient population, you need to go up on the dosage of vitamin D, could be as much as 4,000 international units a day to achieve circulating 25 hydroxy D levels greater than 30 nanograms per ml, which is what I would aim for somebody who is at risk. Now that so for my patient that I have presented, I would choose an estrogen-based strategy because of her symptoms, because of her personal fracture risk. And then once I've initiated some treatment, I should be monitoring that things are working. And I could monitor with repeat bone mineral density. I would check it 1 year after I start the treatment. And if stable, then do it 2 to 5 years later. I may check a bone marker to make sure that she's indeed taking her medication if I'm worried about compliance. So after initiating an anti-resorptive therapy, I should expect greater than 30% decline in bone markers, which is consistent with efficacy as well as compliance. Now that I have started menopausal hormonal therapy, the big question is, how long do I continue for? This is only a 46-year-old woman. Average age of menopause in Caucasians is 51. So I can surely continue to use hormonal therapy till the average age of menopause before reassessing where I need to go. I just want to underscore the importance that when I stop hormone therapy, or when I stop PTH, or when I stop denosumab, the bone loss happens immediately. So drug holiday concept, stopping hormonal therapy in this particular patient, that our case, I would have to think about, where do I go next? Because she has a low retirement account. I have stabilized it for the number of years that I have maintained her hormonal therapy. And now I have to balance safety of hormonal therapy in an aging person with benefit for the skeleton. And maybe somewhere along the line, I would switch her from hormonal therapy to a bisphosphonate therapy as she approaches her mid-50s, as a strategy to keep her bone from skeleton from loss as she's aging. So the concept of drug holiday in a perimenopausal woman really needs to be clarified in the context of what agent am I looking at. So back to our case, is she at fracture risk? Yes. Should she initiate a fracture therapy? I would advise that based on her entire risk profile. What therapy would I choose for her? I would choose a menopausal hormonal therapy, transdermal estrogen with periodic progesterone exposure, because she does have a uterus, to minimize her risk for endometrial cancer. Progesterone should be offered, or TSEC, which does not require progesterone, because BZA negates the effects of conjugated equine estrogen at the level of the endometrium. So these are the two choices I would choose for this perimenopausal patient. So the take-home points I'm hoping I've been able to convey is that the fracture risk must be individualized, and the choice of treatment must take into account the risk burden, fracture risk burden for the patient, skeletal site-specific considerations, what are the comorbidities, how much longevity is this a person I'm expecting ahead, what are the patient's concerns and her preferences. TSEC, place in perspective if it's available to you. I would say this may be the optimal strategy. It addresses psychological stress that she has for her personal risk for breast cancer based on her sister's experience, and I would monitor her thyroid status. So I hope I've been able to address the learning objectives that I started with, that we should appreciate the relationship between ovarian physiology and bone health, understand the determinants of bone mass, define low bone mass, appreciate the relationship between low bone mass and fracture risk. I'm sorry that got missed, and then tailor the management based on individual patient profiles. So with that, I thank you for your attention. My thanks to EMAS for this opportunity, and I'm available to answer any questions that you may have. Thank you so much, Ronimus. Back to you.
Thank you so much, Doctor, for such a nice and informative presentation. And now I think we can wait a few minutes and let's have some questions from the audience. So
Perfect.
Please use the chat option, audience, and you can ask. Okay. So we can leave like 2 minutes for this
Sure.
this procedure. So it seems that there was no questions so far, so I guess we can conclude the presentation and webinar. Thank you so much for your wonderful presentation, Dr. Paul, and
Thank you.
all attendees for being here today. Thank you, everyone, and have a great rest of the day. Thank you.
Thanks so much. Bye.
Thank you. Bye-bye. Thank you.